Hello, everyone. So congratulations for hanging in. It's the end of the day. It's been an exciting day. We just have, 4 unique presentations to run through now. This is using the PechaKucha style. So these are research studies that will be presented just using pictures and some narrative. And the exciting thing about this part of the day is that you have the opportunity to pool to vote which of these 4 is the best. Now, you just wait until we have the final presentation come through, and then, we will tell you when to start voting. And we have a prize for the best presentation. So I'll be running this session together with Helen, my colleague, Dr. Helen Nabuera, and we will listen to each presentation, and then we will discuss some key points from the presentation as it links to, the process of implementation science, implementation research. And then you will have the opportunity to vote for, the best at the end of all 4 presentations. Okay? So can we please have the first PechaKucha style presentation? Thank you.
Hi everybody, my name is Valentina and I work at the University of Manchester. I present a qualitative study on the impact of communication on women's experience of grief following stillbirth in Malawi, Tanzania and Zambia. So communication is an important component of care, and when parents experience a traumatic event such as stillbirth, the communication of that needs to be done in a respectful and sensitive way by the provider. From the literature, we know that parents appreciate that the information are clear, honest and timely, especially about the death of their baby. They want to know the cause of death to prevent another stillbirth. And they will have a very long-term memory about the language, the gesture, and the behavior of the providers. On the other hand, when the messages are poor, there is lack of confidence of the providers, or there is lack of reassuring words and empathy, this creates frustration and anxiety and make parents doubt the clinical explanation of that.
Yes, so I think we had a problem there with, the first presentation. Are we going to try and play it again, or do we move to the next one? Move on. I'll start the next one now. Okay, thank you.
Sub-Saharan Africa is undergoing a massive demographic and nutritional transition associated with rapid urbanisation and adoption of what we traditionally call Western or affluent lifestyles. But these terms are outdated and misleading. Simple sugars and refined carbohydrates, they're quickly becoming cheap and convenient ways to feed a family, not only in the West, but the bulging cities of Sub-Saharan Africa too. Non-communicable conditions such as diabetes and hypertension are therefore becoming pressing public health priorities in the region. The impact of overt forms of diabetes and hypertension on poor pregnancy outcomes are well documented. In addition, recent evidence suggests that moderate elevations in blood glucose and blood pressure also increase the risk of adverse outcomes. However, the majority of these studies have been conducted in Caucasian populations and in the high-income setting. Not only are there possible differences in the phenotypes of these conditions in different populations, what kind of management can be offered clearly depends on the resources that are available. Caution must be taken when translating the evidence between such vastly different settings. The aim of this study, therefore, was to determine the contribution of moderate elevations in blood glucose and blood pressure to poor pregnancy outcomes in Ugandan women. The study was undertaken in 5 major hospitals in urban and peri-urban central Uganda and was a nested study within a wider study to understand the determinants of hypoglycemia in pregnancy there. Women in the antenatal clinic were approached between 24 and 28 weeks and invited to take part. Exclusion criteria included major comorbidities such as heart failure or kidney disease, or a prior diagnosis of diabetes mellitus, or an established diagnosis of preeclampsia in that pregnancy. Women were given information to take away and then returned for full enrolment. They filled a study questionnaire detailing demographics and obstetric history. Anthropometrics such as height and weight were measured. 3 blood pressure readings were taken. We were using an automated Omron machine, embarrassingly not the cradle device. Women had been asked to fast overnight. They did a full 75-gram oral glucose tolerance test, though this was a nested study, and we were only really interested in the fasting venous blood glucose, as this is arguably the most feasible way of screening for hypoglycemia in pregnancy in this setting. All samples were immediately centrifuged, refrigerated, and subsequently analysed at the central MRC laboratories within 24 hours. Women with overt diabetes or hypertension were excluded from our analysis. These were defined as a fasting venous blood glucose of more than 7.1. That's the international cutoff for overt diabetes in pregnancy. And a mean arterial pressure of more than 107 millimetres of mercury. So that's equivalent of 140/90. A moderate elevation in blood glucose was therefore defined as a fasting sugar between 5.1 and 7.1, and a moderate elevation in blood pressure defined as a mean arterial pressure between 90 and 107. The primary outcomes of interest were large birth weight babies, that is above the 90th centile, and perinatal death. We used multiple logistic regression analysis to determine the contribution of our variables of interest, our moderate elevations, as well as other confounding variables such as body mass index, age, HIV status, health facility, to name but a few. Overall, almost 5,000 women were approached, of whom just under 4,000 enrolled. Of these, around 3,000 were included in the analysis, with the others missing key laboratory or outcome data. 66 women were excluded because they had either established hypertension or a blood glucose in the overt diabetes range. So what did we find? Of our 2 variables of interest, moderate elevations in blood pressure, but not blood glucose, were associated with an increased odds of perinatal death. So women with a mean arterial pressure of more than 90, but less than 107, equivalent to 140/80, were twice as likely to lose their baby than other mothers. Neither of our 2 variables were significantly associated with large birth weight babies. There was a positive trend between blood glucose and large birth weight, with an adjusted odds ratio of 1.33, but with a confidence interval of 0.94 to 1.90. One could argue, of course, that this is due to small study effect size. But what's really interesting is that the independent contribution of obesity clearly outweighs that of moderate elevations in blood glucose. So women with a mid-trimester BMI of more than 30 had an adjusted odds ratio of 2.30, confidence interval 1.75 to 3.02. A notable and encouraging finding is that a self-report of previous macrosomia also independently predicted large birth weight with an adjusted odds ratio of 2.47. So what does all this mean, and what are the clinical implications? Well, measuring blood sugar is an expensive business, and managing moderate hypoglycemia is resource intensive. This photograph shows the typical number of glucose measurements a woman may be able to afford throughout the entirety of her pregnancy. On top of this, we already know that managing mild forms of GDM doesn't really reduce many of the important pregnancy outcomes of interest anyway, and that's even with expensive measures such as capillary blood glucose measuring 4 times a day and insulin therapy. In an environment where resources are so limited, there would have to be a very good reason to focus on blood sugar. And while this clearly isn't a cost-benefit analysis, our results suggest other factors are likely more important. Encouragingly, the identification of obesity and previous history of macrosomia are as good as free, and are clearly associated with poor pregnancy outcomes. Focusing on these, perhaps triaging women into higher risk antenatal care streams, and working on interventions that mitigate risk, may offer more value for money than focus on blood sugar analysis, for example. As for blood pressure, our findings highlight the importance of recognising risk with blood pressure readings that are below the international standard set to escalate care, that's 140/90. Unfortunately, many settings still struggle with identifying even established hypertensive disorders in pregnancy, let alone more moderate elevations. So, to reiterate the headlines, moderate elevations in blood pressure are associated with perinatal death, and large birth weight seems more closely associated with obesity than moderate elevations in blood sugar. Thanks for listening, and a big thank you to all my colleagues in Uganda too.
Yes, thank you, Jack. That was an excellent presentation. Helen, how did you find that presentation? How does it link to, the overall theme of implementation science we've been hearing about today?
Yeah, I think it's really important. I think today we focused a lot on interventions, but what Jack's presentation is doing is taking us back to actually identifying what the problem is, and then the next steps obviously will be what we've been discussing a lot today, how you then develop interventions. And I think that is key in terms of identifying what's the priority in this setting, what is the problem, to then going on to develop the intervention. And I guess we focus a lot on core development of the intervention. So both the researcher, the stakeholders in the country who should involve the patients as well.
Yes, excellent. I mean, I really like one of the things he said in the beginning where he says, it will be difficult for us to transpose evidence from a different setting into a local setting. Yeah. And so whereas we know exactly what works elsewhere, we needed to look for the local evidence. Probably because of the length of the presentation allowed, I would have liked to see him emphasize how, the local stakeholders were involved in designing the research and, the link to the uptake of the research just for sustainability, as we have said. But I think it was a very important, research about a local problem, and a recognition that, there is not a universal solution. That context is quite important, as came out from Sally's presentation.
That's right.
Okay,
Yep.
Excellent. So I think we'll move swiftly to the next presentation, and we have a brief chat again after that presentation. Thank you.
Hi, my name is Georgina Page and I work with the Evidence to Action team at Mary Stopes International. MSI is a global organization. We work in 37 countries providing sexual and reproductive health services. I'm going to walk you through our experience of using human-centered design to develop an intervention to improve access to family planning for adolescents in the Sahel. For MSI, our clients are at the heart of everything that we do. Ensuring we are delivering respectful and non-judgmental services to those that need us most is core to our mission. We work in 4 countries in the Sahel: Burkina Faso, Mali, Niger, and Senegal. And one of the biggest challenges remaining in this region is how to expand access to family planning for adolescents under the age of 20. Our research indicates that lower use among this group is driven by misunderstandings of side effects and concerns about future fertility. Newly married adolescents are under intense social pressure to prove their fertility, and this makes them and those influencing their decisions, like husbands and older female family members, really suspicious of anything that might jeopardize this. So, in 2017, MSI launched a project with the support of the William and Flora Hewlett Foundation and design agency IDEO.org to use human-centered design to develop an intervention focused on improving access to family planning for rural Burkina Faso adolescent mothers in the areas where we have mobile outreach service delivery teams. While existing MSI and secondary research provides some insights into the experiences of these young women, adolescents in the Sahel context often lack a voice when it comes to the issues that most affect them. We chose to use human-centered design to make sure that whatever solutions we came up with were developed with these young women central to the process. Immersive qualitative design research at the beginning of the project in rural Burkina Faso allowed us to understand not just adolescent women's experiences of attitudes towards family planning, but also how this relates to their lives more generally, in terms of their future aspirations, family decision-making, and other influences on their lives. In synthesizing the findings from the design research, we were able to build a picture of the different types of adolescent women we were designing for. With a better idea of their engagement with and knowledge of family planning, as well as their hopes and fears for the future, we were able to start to identify opportunity areas where we might be able to introduce interventions to help expand their access to family planning services. Once we had some of these rough ideas, we started to prototype them. A key principle of human-centered design is to iterate and test your ideas throughout the process. This is a great way to involve those you are designing for in developing the tools and solutions, and to learn quickly from them what works and what changes that you might need to make. As soon as we had some initial prototypes, we took these back to rural Burkina Faso to test them. We took 5 different prototypes back to the field and created several more while we were there, directly building on what people were telling us as they tested them with us. Feedback from these tests pointed to 2 prototypes which were likely worth developing further. One of the most successful prototypes was a community board game. This proved effective in tests at opening up positive discussions about contraception among the wider community and engaging men in these conversations. Young women told us during the design research that community resistance to family planning and a lack of male engagement were major barriers to them being able to take up a service. To complement increased acceptance at the community level, our second successful prototype sought to encourage couples to discuss family planning in the context of the future of their family. And we developed a set of visual cards to be used during a facilitated conversation to help enable this. Once we had identified the prototypes that appeared to best meet the needs of our users, it was time to test them at small scale in a much more real-life setting. So 4 of our fantastic mobilizers in the PechaKucha teams started to use the game and the conversation cards in their day-to-day mobilization activities, and they did this for 3 months to help us really understand how they were working and what changes we might need to make. After a few minor iterations, including some waterproofing to deal with the rainy season, we had our pilot version of La Famille Ideale. This consists the community board game, working and supporting increased overall acceptance of family planning use, and the facilitated couples conversations to help enable shared decision making. These are both coordinated around the delivery of quality SRH services by our MSI PechaKucha teams. A rapid evaluation at the end of the pilot phase indicated that exploring family planning in the context of overall family aspirations like education and financial security, including a myth-busting quiz and lighthearted role plays, meant that the board game especially was able to create a positive community dialogue about contraception not achieved in other types of mobilization activities. This success was reflected by improvements in the number of adolescents accessing services with the PechaKucha teams who were piloting the tools. There were improvements over time among these teams and compared to teams that were not using the tools, indicating a positive impact on our overall project objective. The evaluation also highlighted important recommendations for how to use HCD at MSI. This is colleagues from our Niger program playing the La Famille Ideale board game. And ensuring engagement like this among those who will be involved in supporting and using the intervention is critical to a successful rollout. They are also your users and you need to involve them throughout the process. A secondary objective of the project was to explore how to adapt La Famille Ideale for use elsewhere. We often transfer approaches directly from one context to another, but in this instance, the use of rapid insight gathering and iterative testing of the existing La Famille Ideale tools showed us just how critical it is to take the time to adapt properly. Iterations to the game included changes to the visuals, contextualizing the technical information provided, as well as really thinking through how the tools were going to be integrated into existing MSI systems and approaches in each country. Senegal and Niger now have their own versions of each of the tools, the board game and the conversation cards, which they're piloting. These rollouts continue with multiple mechanisms for continued learning integrated into them. These include monitoring the use of the tools through activity tracking and supervision, tracking the number of clients accessing MSI services who participated in a La Famille Ideale activity, and we plan a more in-depth evaluation to explore the impact of the tools on the attitudes, intentions, and behaviors of the young women, men, and community members they're designed to support. Whatever we learn from the pilots, our objective will be to continue to iterate and adapt our approaches to expand access to quality family planning services for adolescents across the Sahel.
Right. That was Georgina Page's presentation. Again, another very good presentation. So maybe, Charles, you could tell me what your best aspects of that presentation were.
I think it was really very clear, and then
Yeah.
it really brought out some very interesting points that was emphasized throughout the day. So involving local population stakeholders to really identify what the problem is, and they were part of designing the intervention from the start. I think I really like that about this one. And then importantly, it was an iterative process. So they kept learning as they went along. They tested, got more information. Even while they were in the field, with the prototypes, they kept modifying and learning. And then there was an inbuilt evaluation component where they documented lessons learned. And quite interestingly, even when they got this generic board game, they could adapt it with slight modifications for 3 other settings. And then they had embedded into this an evaluation at the end to see how it works, to measure, what they had set out to achieve. So I think that that was really comprehensive in terms of the whole idea of implementation science.
Absolutely. And I guess when you're setting out to do a research project, you obviously have an endpoint, and sometimes there's a feeling that having iterations may delay your endpoint, but actually there's so much value, as you rightly say, the richness of the information and the intervention in terms of how they've developed it. The endpoint actually is a much more valuable tool for the population that they're going to be working in. And I guess that draws on the fact that actually when you engage people in terms of the acceptability of that intervention, you've actually incorporated all those aspects in that process.
Yes.
And it actually, in the end, shortens the duration of time of getting it to be translated into practice. So, yeah, absolutely excellent presentation.
Absolutely. And, I think I like the, in the end, in terms of rolling it out, they had this community mobilization.
That's right.
And Sally and I think Imelda talked about the importance of the sort of local implementation teams.
Yeah.
So they are known to the local population, and so they've been part of the process.
Yeah.
So they can troubleshoot and still learn in that process, even at the rollout phase. So I think this is a very good implementation science project.
Yeah.
Designing intervention from start, learning all along the way, and also having an inbuilt evaluation mechanism.
That's right. Great.
Fantastic.
Yeah, well done.
Okay, so I think we'll now move to the next one.
My name is Victoria Kincaid, and I'm currently a Foundation Year 2 doctor. I will be presenting my Master's and a medical school elective work, which I conducted via my medical school, the University of Aberdeen, and with the charity The Soapbox Collaborative. The title of this work is Implementing a Photo Action Tool, or PAT, to manage overcrowding in maternity wards in low to middle income countries. Overcrowding is defined as the presence of more people or things in a space than is comfortable, safe or permissible. It is pervasive throughout our global society, with the population expanding at a rate that cannot be sustained by the natural resources of the planet. This image is pretty familiar in recent times, with beaches and places being crowded. We can observe overcrowding acutely in healthcare settings throughout the world, where supply cannot meet demand and which compromises patient safety. Current media and research primarily focuses on emergency department overcrowding. However, it occurs in all departments of the hospital, particularly those with a high turnover of patients. One example of such a ward is the maternity ward. Despite this, there is currently no research on overcrowding in maternity departments in any resource setting, nor is there a standardised definition. This crowding is exacerbated further in low to middle income countries, where resources and infrastructure are poor, and demand far outstrips supply due to economic factors, high birth rates, famine, drought, and war. Maternity wards are becoming increasingly busier due to an increase in demand for facility deliveries, with up to 75% of deliveries now occurring in healthcare facilities. This demand, however, has not been met by an equivocal rise in resources in low to middle income countries. Maternity ward overcrowding has a plethora of adverse consequences, both for mothers and babies. Increased risk of healthcare associated infections, neglect and violence from overstretched staff, and unnecessary C-sections, to name just a few. Long term, this may result in women not coming to facilities to deliver. Why is this important? Well, it can lead to an increase in preventable maternal and newborn mortality. Therefore, overcrowding on maternity wards is an important factor to consider if we are to achieve the Sustainable Development Goal 3.1 of reducing global maternity mortality ratio to 70 in 100,000 live births. So, maternity ward overcrowding must have a universal definition and mode of measurement for it to be combated effectively. And this measurement method must be multidimensional to encompass the complexities of the maternity ward. To examine this further, primary research was conducted in a low to middle income country, Ethiopia. Phase 1 of the research was a literature review, highlighting distinct lack of papers describing overcrowding on the maternity wards. Most of the information which was used came from papers based on emergency department. So this is an example of the checklist that was created from the literature review. Data was collected in a checklist over a 5-day period for at least 3 time periods a day, and pictures were taken alongside the checklist as a visual correlation, and that made up the PAT, or the photo action tool. So phase 2 of the primary fieldwork was trialling the checklist on the maternity ward in Ethiopia, and supplementary data was also used. Staff assisted in taking the photographs due to the constraints of language, and consent was obtained in each photo in each clinical area. Then key informant interviews were conducted using a series of questions in relation to what the PAT was basically showing us. This gave us valuable insight into the functioning of the ward and the feasibility of the PAT. So phase 2 was concluded by deeming the PAT was useful in combating overcrowding. So then phase 3 was carried out 9 months later, and that was the pilot study itself. The data was collected 3 times a day for 4 days, and for each interval, basically, it was a 15-minute period where staff and patients were counted on in a clinical area, and then a photo was taken to correlate the data with the checklist itself. After this data was collected, then stakeholder interviews were conducted over a 4-day period, and basically we showed the data and the photographs to see what the key stakeholders had to say. And the pie chart shows the professions of the 8 interviewees. Of the 8, 4 were assigned by the researcher to see the graphs first and then the photographs. So they looked at the data first and then the photographs, and then the other 4 saw the photographs first and then the graphs. The interviewees were very surprised by the issues caused by overcrowding, which the PAT highlighted, but despite this, the interviewees believed that the data they were shown in the PAT was accurate and reliable and presented an accurate picture of the situation on the wards. This is a stock photo, however, it resembles a lot of the photos that were taken by the PAT. One thing that stood out was that most interviewees were shocked by the number of visitors of the ward and the lack of visitor activity. So ideally, a manager could look at a photo like this and see a clear solution to the overcrowding problem. So it was concluded that the photo aspect of the PAT was effective in highlighting problem areas in the ward, such as overcrowding. The photo aspect gives an accurate way of combating overcrowding. However, it's inconclusive whether the photos alone would be enough to stimulate change, but it could definitely be argued that the PAT is effective in raising awareness of the situation and stimulating change, and photographs add a useful aspect to this. So this kind of awareness raising tool is useful in overall helping improve maternal and newborn health, and can be tested in other resource settings throughout the world. I'd like to thank you for listening and would welcome any questions you may have. Thank you.
Thank you. So that was another exciting presentation. Helen, what do you think about that presentation as it relates to the theme of implementation science?
Yeah, I think it just points towards what Professor Sally Theobald was saying in terms of the range of tools and methods that you can use within implementation research. And I guess this one really points more towards more visual. So especially, I think, for stakeholders who may not have direct access or direct contact with patients. And just in terms of an aspect that we've discussed in our session around advocacy and how you can generate that interest in addressing a problem. I think, the researchers have gone through relative iterative processes. I know there's a lot more that can be done just to refine the process, but I thought it was really useful, especially in really advocating for the need for, more infrastructural changes or even processes to ensure that, women are not exposed to these overcrowded situations that exposes them to risks of poor outcomes.
Yeah, absolutely. So, I mean, it's interesting to see, some innovation around a tool that can be used to advocate for improved quality of care for women. So still going around the theme of respectful maternity care.
That's right.
So this is a new tool, new innovation. Probably needs a bit more extensive testing, but I mean, it just shows you how we need to come up with, context-specific solutions as part of the whole process of implementation science.
That's right. That's right.
So I think as we begin to wrap up, I want to say that I hope you've all enjoyed, those presentations. We're sorry for the technical problem with the first presentation. We lost sound after 2 minutes, and so you probably did not get the full story from that presentation, and that may be difficult to judge the, that presentation. However, the polling is now open. If you go to the polling's button under this session, you have the 4 presentations listed, and I can remind you who is who. So Valentina Actis was the first presentation that was not clear, stopped 2 minutes down the line. Victoria Kinkard was the last presentation you heard about the using photographs. Jack Millen was the second presentation, the one that looked at diabetes and moderate hypertension. And the Georgina Page's presentation was the one on
La Famille Ideal.
Yes, was the one on family planning, creating demand for family planning, using board games. So the poll is now open. We will leave it open for the next about 5 minutes, and then we will announce the winner. So we have a prize for the winner. So while you are voting, now after you select, you make your vote, you need to press the submit button, which is down at the bottom. If you can't see it, scroll up, and then you click on the submit. Then your vote will count. So we'll close this after 5 minutes and announce the winner. While you're doing that, we can just give a summary of the day and give some instructions for tomorrow. So we had an exciting session today. We had 2 very interesting keynote speakers, Professor Sally Theobald and Annie Patella from the WHO. We also had, several parallel sessions. One parallel session was on the NHIR group, research groups, and we heard from Professor Delia Numba and Professor Tina Lavender. We also had a panel session, where we discussed and looked at key examples, frameworks for implementation science. Particularly, we looked at a systematic approach to capacity building within implementation science. And again, several key points were emphasized over and over and again. The involvement of stakeholders right from the start, having a robust plan right from the start, how you build local capacity, what you put in place to ensure ownership. There was a lot of talk about the importance of it's all an iterative process. There are some trade-offs between, pure science and implementation science. Implementation science addresses, context-specific barriers that lead to, non-uptake of research findings in local settings. So really involving and acknowledging the input of local stakeholders is very important for success. And we heard from the NHIR sessions and also from the presentation from Professor Bates that a lot of the research funders, UKRI and NHIR, they really expect you to embed, the concept of community engagement and involvement, engaging the community, and also local capacity building. So these are very important concepts that they want to see in your proposals. A lot of the slides, all the presentations are there online. They're very rich content, and we will make this available on the website through the app for the next 1 year. So you can really go back and look at these key concepts. And the app allows you to get in touch with the various speakers, and they will be able to take any specific questions you have. Just before this session, we had 3 exciting workshops that looked at practical research experience from various settings as relates to maternal health. So these are very important learnings that you can transfer into some of your future research designs. So tomorrow is the last day of the conference. Again, we start promptly at 10 minutes to 9.
Yep.
I think, yes. We start, yes, yeah. So, and we have a very rich program tomorrow. I think just in the spirit of implementation science, the iterative process, we have learned a lot from today. So bear with us, tomorrow will be smoother. I can guarantee that. So tomorrow will be a lot smoother. We have, a very exciting keynotes, panels tomorrow, so I will encourage you to log in and participate. Now the polls are closed, and I'm pleased to announce the winner is Georgina Page. So the presentation on how an intervention was developed from grassroots through an iterative process to improve advocacy, communication, discussion within the community about family planning. And we know that in some of these settings, these are not issues that are discussed openly. So, this was almost 4 out of every 10 votes went to Georgina Page, so 43% overall. So congratulations to Georgina. So you're going to get from the conference secretariat your prize, which is an Amazon voucher. So thank you very much. Helen, do you have any closing words for?
Yeah, so I guess I wanted to really say that the audience have been really key to this conference. I think everyone's engagement, the questions that have come through have really enriched all the discussions throughout, the conference. So just to thank you as the audience for your participation. Obviously, this is the first time GLOW has been done virtually like this, so there are many lessons that we will learn from it. But it's been great just really having your engagement in helping us succeed at what we are doing here. So thank you very much. And to all the presenters, all the hard work that they've put in recording and then being there to answer questions, it's been fantastic. Thank you.
Excellent. So, big shout out again to all our presenters, all the members of the organizing committee, and the crew. The filming crew, the crew behind the app. They've been working flat out to ensure that we have an excellent online conference. And the participation, from what we've monitored, the interest has been really phenomenal. So let's continue breaking the record, and let's do it again tomorrow. So have a good evening, everyone. Thank you.